Morning. My disclosures are on the American Academy website. Trochanteric fractures are a common injury in the older population. They account for approximately half of all hip fractures. They can lead to significant declines in patient function and health-related quality of life, and there's a lack of conclusive evidence supporting any one treatment type. Use of an intramedullary device is common for intertrochanteric fractures. As of 2017, more than 90% of intertrochanteric fractures were being fixed with an intramedullary nail. To consider when managing the intertrochanteric fracture include the fracture pattern, what is an acceptable reduction, and what is acceptable implant position. A number of factors to worry about preoperatively when managing the intertrochanteric fracture. These include the presence of unstable fracture patterns, reverse obliquity, subtrochanteric extension, a thin lateral wall, significant displacement, and femoral bow. These factors dictate implant choice and approach. These radiographs show a very unstable fracture pattern with subtrochanteric extension and a thin lateral wall. This was treated with a sliding hip screw and predictably failed early on. If lateral wall thickness is less than 2 centimeters, the fracture should not be treated with a sliding hip screw alone. Significant displacement can also lead to significant challenges. If the fracture is more than 100% displaced, open reduction is required. These radiographs show the previous fracture which required open reduction to achieve satisfactory reduction and implant placement. These radiographs show a case with significant displacement where open reduction was not performed. One can see the poor reduction and poor implant placement as a result. Preoperative assessment of femoral bow is also critical, particularly when using a long nail. One must ensure that the nail radius of curvature is appropriate for the femur. Screw cutout is still a problem both for nails and plates. Reduction is absolutely key. The focus has been on the implant and less on reduction, but there is a very strong association between immediate postoperative reduction and improved outcomes. An acceptable reduction occurs when the anteromedial calcar is reduced. You want to avoid translation, negative medial cortical support, and anterior malreduction. One must also restore the neck shaft angle and avoid varus and avoid distraction. One must absolutely do what it takes to get reduction. If necessary, the fracture should be opened and adjunctive techniques should be employed. Implant position is also absolutely key. Tip to apex distance has been very valuable in predicting failure of fixation of plates when treating intertrochanteric fractures of the hip. Similarly, screw position for cephalomedullary nails should either be center-center or inferior center for optimal results. So cutout really has little to do with choice of implant. It has mostly to do with improper surgical technique related to poor quality of reduction or poor implant application. So some tips for success when using an IM nail, which is the most common implant used in 2025. You really want to make sure you've reduced the fracture before reaming. You want to ensure that you have a correct entry point. When reaming, you want to avoid further comminution and lateral drift. You want to be aware of the lag screw angle. You want to be aware of distal nail perforation. You want to check for rotational deformity. And you want to ensure that there's atraumatic manual nail insertion. There has been a lot of literature suggesting that there is no difference between nails and plates when treating an intertrochanteric fracture. We wanted to address this issue and perform a study to determine whether really there was no difference between nails and plates. As a result, we undertook the INSIGHT trial, which was a comparison of intramedullary hip screws versus sliding hip screws in the management of trochanteric fractures. This study was published in JAMA Network Open. This was a multi-center international RCT. Patients were randomized across 25 sites. There were 850 patients included in the trial. Eligibility criteria are listed. We found no difference in our primary outcome, the EQ5D, between the two groups at any time point. There was no difference in terms of mobility and function between the two groups. There was no difference in adverse events, unhealed fractures at 13 weeks, and revision surgery between the two groups. So we found in ambulatory patients with both stable and unstable intertrochanteric fractures, no significant differences in health-related quality of life, revision surgery, and fracture healing between an IM nail and a sliding hip screw. These findings, in our opinion, don't support the increased use of intramedullary nailing for managing all trochanteric fractures, and the sliding hip screw still has a role to play, particularly for stable fractures, given its lower cost. So if you look at the evidence for the device in 2025, biomechanical results are not supported by clinical results at long-term follow-ups. There are no pivotal prospective RCTs that have shown superior outcomes with any implant or fixation method. I think what's particularly important is that data in the high-functioning patient is lacking, particularly at long-term follow-up. While the evidence suggests there are no differences between IM nails and sliding hip screws, I think there are some exceptions. IM nails are preferred in very unstable patterns in high-demand patients, in reverse obliquity patterns, in patterns with subtrochanteric extension, and when there's a thin lateral wall. I think what doesn't matter so much is nail diameter and nail design. For nail diameter, a 10 millimeter nail works well, and it really isn't necessary to fill the canal with a nail. For nail design, integrated lag screw fixation has been promoted, but really outcomes are mixed, and this is still a very controversial topic. The recent literature around dual versus single lag screw designs emphasizes this controversy. There have been 3 papers recently published in the JBJS. In the first paper for subtrochanteric and reverse oblique fractures, dual lag screw designs had a lower risk of mechanical failure. In the second, the intertan nail had a higher risk of aseptic revision versus single screw designs in long nails rather than short nails. And in the final paper, an integrated dual lag screw design was associated with significantly higher odds of reoperation for fixation failure and all-cause reoperation. What about the use of a short versus a long nail? The ideal length of intramedullary implants for the fixation of trochanteric fractures remains under debate. In a sub-study of the INSIGHT trial, there were more fracture-related adverse events, more soft tissue infections, and more pain with a long nail versus a short nail. Function was no different between a short and a long nail. I think the take-home message is that the vast majority of intertrochanteric fractures managed with a nail can be safely treated with a short nail. So if you're looking at the bottom line for intertrochanteric fractures, outcome is most related to proper surgical technique, specifically the quality of reduction and implant application. No pivotal RCTs have shown superior fixation with any specific device or method. Primary treatment is with well-done internal fixation in the vast majority of cases. Thank you.